All right. Well, thank you for joining us tonight. We've got a good session. We're going to keep it dynamic. Please shoot us with your questions, and we'll do our best to tackle those. The overarching theme of tonight is biology, biologics, hardware. How do we find the sweet spot of bringing these all together? So this will be some didactic, but also a lot of cases. Thanks to our faculty, all really solid guys, a lot of experience here. So again, if you have questions, it's really easy to lean on these guys. So what do we got? Well, let's start with a challenging case. And this one's mine, and you will probably have some criticisms, and I'm okay with that. So this is a 30-year-old male. He's a laborer with a history of trauma. He's had this tibia pilon fracture, and he's developed post-traumatic arthritis. So I did an anterior approach, ankle fusion with 2 screws. That is not how I would do it in 2025, but that's how I did it then. And then I ran him through my post-op course, which would be non-weight bearing for a few months, and then gradual weight bearing from there. So 1 year later, he's back and he still has pain. I look at his x-rays and I go, I don't know, that looks pretty good. I can see the joint space, and all in all, looks pretty good from my point of view. But if I then do a CT and I look at it, I go, boy, not really as good as I really thought. Is what I've got going on here is my X-rays are way overcalling what I've got, and so. Really, I've got a non-union, and if there's no sugarcoating that, there's nothing there that's healed. So how do we call fusion? Well, clinically, improvement in pain, function, swelling. That's easy. We've got tools that measure it, but what about imaging? Well, historically, we've gone on these radiographic criteria. Not so good. Joint space obliterated, and then trabecular bridging across fusion site. Well, Mike Coughlin and Carol Jones first poked holes in the idea of using x-rays for follow-up of fusion, and they used the subtalar arthrodesis model. They were interested in the percent of fusion measured using x-rays and compare that to CT, and then bring in some patient outcome surveys. So what they learned here is that x-rays way overcall what we have for fusion. So at every time sequence, CT was dramatically less than what the x-rays were saying. So the takeaways from this is CT is way better than x-ray, and I think we all universally agree with that, but not as much fusion as we thought we were getting. So Mark Glazebrook took another look at this. This is a level 1 study, 275 patients in a hindfoot fusion study, and they're looking at clinical outcomes. And in this paper, they're trying to correlate clinical outcomes to the amount of fusion you have. So the question is how much fusion do you have to get to be good? So taking their x-rays, in this case, I'm showing you ankle fusion examples. Osseous bridging was judged as absent, 0 to 24, minimal 25 to 50, moderate 50 to 75, or complete 75 to 100. This slide's a little mixed up. What it says is that if you have 25% osseous bridging at 12 weeks, that's a very strong indication that you will be good at 1 year. They also found that 50% osseous bridging correlated to good outcomes. So the answer is, how much fusion do you have to get? It's 50%. It's not 100%. In fact, in these well-controlled studies, very few patients get 100%. So how do we get to 50% if that's the number we're going? Well, this is another level 1 study coming out of the same data set. And this question was, if we use graft, does it matter? So this is a really interesting one because they've taught the surgeons how to put in the graft, and then they've said, let's go ahead and do it. So they're going to quantify graft fill at 9 weeks, and we want to understand how much is there. Again, fusion is defined as 50% bridging bone at 24 weeks on CT. So this just shows how good we're not. Even though all surgeons were instructed on how to do graft, 82% actually got it right. But of the ones that did have adequate graft fill, the odds ratio was 16.4 times higher that they would get a successful fusion. So the lesson here is graft fill greater than 50% is associated with improved fusion rates, and you need to be grafting your fusions. So I can't think of a fusion where I wouldn't graft. So the upshot of all of this in the literature is successful fusion's not straightforward. We're probably not as good as we think we are. CT at 12 weeks, showing 25% osseous bridging and a hindfoot fusion correlates to good long-term success. Improved clinical outcomes happen after 50% of radiographic fusion based on CT, and you need to be grafting all your fusions because the dead space needs to be filled. So with that, let's hear from our panel. They're going to go through their ideas, and then I'll bring it back to some conversation after that. Dr. Fusco?
Thank you, Dr. Berlet. So now we get to dive into what is actually the driver of fusion. Is it actually the hardware? Is it the biology? Is it the biologics? And so we all get to present our arguments now. My argument is hardware is king. We're all surgeons here. We've all seen all the reps. We've all seen everybody. I go back to one of the very first things we're ever taught as students and as residents are the AO principles. I was lucky enough to do several AO courses, and these are all kind of hammered into our heads over and over again. And the number one of the things that we always went back to is stable fixation. Every surgery, every arthrodesis that we do is going to require hardware of some point. This can be dynamic, it can be static, it can be internal, external, metal, non-metal, and even some of these, different cases where you may not be putting something in, but you're doing an external splint, you're doing something to stabilize this fixation. It's going to require hardware of some sort. A quick little search shows that there's over 1,100 orthopedic hardware companies currently doing business in the US, but yet there's only 70 bone graft companies. And I look at back and everything I say, and the most important thing that makes me say that, hardware is king is you can't look cool on TikTok or on Instagram if you don't have really cool hardware. So we got to have good hardware. And when we look at hardware, maintains our compression. It allows that bone to actually heal. Your good biology can't overcome bad hardware. If the hardware fails, fusion is unlikely. We know that. That's been proven over and over in all the literature. And then when we're looking at our x-rays, the plain film x-rays, the hallmark of a failure is a hardware failure. If you see loosening, if you see hardware breaking, you know that fusion did not happen because there is movement happening there. And so that kind of points us towards, okay, for as far as fusions go, the hardware's got to be the most important aspect of it because that's what we're looking at. And good biology and good biologics can't overcome bad hardware, but great hardware can overcome bad biology. We look at all of our fusions that we do with our diabetics, our smokers, our vasculopaths, all of these kind of things. And hardware is the one that is controllable, okay? We can control what hardware we put in. We dictate what hardware we put in. We can't necessarily change their biology. We can throw some of the biologics in there and things like that, but we can't make sure that they're activated and doing what they think they're doing. But we can certainly control the hardware. And my favorite statement is, fusion's not a biologic miracle. It's a mechanical success story. Okay, we're trying to get these bones to go together. And if there's too much movement there, these bones won't grow together. You'll end up with a pseudoarthrosis. And so I wanted to go through one of these cases that we've got. This is a multi-stage reconstruction that we did for a patient, and this is one where hardware is king by absolute no other ifs, ands, or buts about it. This is a super, super sweet young lady. Unfortunately, she's 70 years old. She's completely Charcoted through her leg, through her ankle there. Excuse me. Her talus is gone. She's dislocated, and she is unbraceable. We tried to brace her. The orthotist said she is too grossly unstable to brace. The big problem for this sweet little lady is she is horribly demented. She does not remember anything from 5 minutes prior. So the most prudent course of action was actually probably a below knee amputation for this woman because of her vascular disease, because of everything that she had. But we came together, with the family, with the primary, with everybody, and kind of came to the conclusion that if we did an amputation on this woman, she is likely to stand up, not recall that she doesn't have a leg, and she's going to hit her head, she's going to break her hip, she's going to do something, and a BKA would likely be her demise. And so we elected to try and do a reconstruction on her. her talus was completely gone, completely obliterated. So we went in, we took out the talus, and we used a femoral head allograft. And what we did was we did take and we drilled probably about 100 holes in there, and we packed it with our magnetos. But I looked at this woman and we had to assume there is no way she's going to be non-weight bearing. Number one, she can't remember that she's supposed to be non-weight bearing, and she can't feel it. So she's going to be up on this right away. So we took down her fibula, we split it open and used it as an on-leg graft. We put a TTC nail right through that femoral head. And then we eventually I took her fibula after it was kind of split open into an on-leg graft, and we put a TTC plate over top of it. And then we put a frame over top of that. We were able to keep her frame on for about 6 weeks before she beat up the other leg with it. And then what we were able to do is take off her frame and just watch her healing. And she actually went on to heal beautifully, and she was walking day one. And as soon as we took off that frame, she was walking barefoot. She's walking all over her nursing facility. She was walking at home. She was walking everywhere. And the favorite part that we love to see is, because we had good, stable hardware, we actually were able to see all of this bone incorporate. You could actually see her fibula incorporate into her tibia and incorporate into that iliac crest and all the way down into the calcaneus. And we could actually see bony remodeling over the anterior aspect of that ankle and that subtalar fusion as well. And there's a couple little close-ups of that. So, in summary, when it comes to this, there's no way you could have this kind of fusion. There's no way you could have this kind of patient without excellent hardware, without robust hardware. Basically, just kind of hitting home, without appropriate hardware, without ample hardware, we won't have a fusion.
That's a great case. All right, Mark. Tell us why biology is king, and Tom's full of it with his hardware.
Yeah, thanks. So pleasure to be here and be part of this. And I got tasked with the biology side of this and the thought process that what really drives its decision making, or what drives the fusion. And as I started to think about this, I was really thinking about this, and I've always been taught, and I've taught others too, that really getting a fusion is a race between the bone and the hardware. Like Tom just said, robust hardware is helpful, but at some point, if the bone doesn't heal, the hardware is going to fail. And that's a great case and a great success story. And I wish every one of my cases looked like that in terms of that amount of bone growth and how that looks. But we all know that sometimes we have cases where, despite our best efforts with hardware, and we can put a lot of metal in there, we don't always necessarily see that result. And so what strategies do we have when we're looking at that race to try to achieve that arthrodesis, and what actually wins? So we just talked about fixation. And if we think about this, you're not going to see a whole bunch of literature from me tonight. I thought about this more metaphorically than anything else. The fixation is really the car itself. It's the wheels, it's the suspension, it's the chassis of the car that really is helping to get across the finish line. And that's really what we all want, is to figure out what we need to do to get across the finish line. The car doesn't drive itself, though. So we can put all the fanciest, most expensive components in, but if the car doesn't have an engine, and if there's nobody to drive the car, it's just going to sit there and not really get across that finish line. And when we look at what we're going to hear from after I'm done with Dr. Ng, the orthobiologics are really the engine. It's the fuel that we choose to use. It's the oil that lubricates the engine, and the engine that ultimately helps create the horsepower to drive the process. But what's the sophisticated part of this? What is actually required to make a successful lap, to get that fastest lap, to get across that finish line faster than the competitors? And that really comes down to the patient and their biology. You can have a great car, you can have a great engine, but without someone who knows what to do with it, you're really going to be challenged to have a successful opportunity to win that race. And so patient biology really does have a strong component to what we can do. We obviously can optimize fixation. We can get a driver a better car. We can get a driver a better engine for that car. But ultimately, the car doesn't drive itself. In this instance, obviously, we live in a day and age where that may not necessarily be fully true. But patient biology is a critical part to this story. And without that patient biology, can we cross the finish line at all? If we're truly biologically inert, it's essentially like operating on a cadaver. And despite Dr. Fusco's great fixation, if we're really in a biologically inert environment, regardless of how much metal we put in, or regardless of what orthobiologics we use, we're not going to be able to get to that finish line. And so I think about comorbidity kind of as the pit crew. So what do we have to optimize? What do we have to look at when we're deciding this case and what we're going to do and how we're going to fix it? Obviously, we need to think about fixation. Obviously, we need to think about orthobiologics, but we also have to think about the patient. Ultimately, that's what's going to drive a lot of our decision making, is figuring out how we best get that patient most prepared for the operating room. So diabetes is something obviously that comes into play here, making sure that we have a patient that has an A1C that's as controlled as it can be, understanding that there oftentimes is still some risk associated with this. And there are numbers that we accept for various types of surgeries that we're doing, and depending on the specific instance, ideally everybody that we would operate on has an A1C under 7. Is that reality in the type of work that we do? Probably not. So some people aren't going to be as optimized as others, but obviously has to be a consideration for us. This is a big one. You have somebody that has really severe kidney disease, somebody on dialysis, involvement of a dietitian, involvement of a nephrologist. If you put this patient on a high protein diet before surgery, you could be creating bigger problems for them yet. So really a team approach to understand what you can and can't do in these patients, what type of medications you can have them on before and after, and what you can try to do in timing and optimization to give this patient the best case. But these are some of the most challenging ones that we deal with. Malnutrition, I think this is underappreciated and becoming a bigger deal all the time. And it's not just vitamin D, it's really protein, looking at prealbumin and albumin levels, making sure that you have somebody that's appropriately nourished. Vitamin D, calcium, parathyroid, from the metabolic bone standpoint. History of gastric bypass and malabsorption, I think this is a big one that goes underappreciated sometimes. Sometimes the people that have had gastric bypass, depending on the type of procedure they've had, may not have the ability to absorb the same nutrients and vitamins as someone who hasn't had that procedure. And although some patients may be large, that doesn't necessarily mean that they have the appropriate protein and they're not nutritionally aligned with what they need to be for optimal healing. So all things to consideration for involving nutritionists, primary care physicians, dietitians, as well as we're looking to try to optimize these patients. Osteoporosis, metabolic bone health, when and if do we need to incorporate endocrinology in this? And that falls into a couple of these categories. Obviously, diabetes, malnutrition, osteoporosis, a lot of that can influence metabolic bone health, and all of those can kind of fall to our friends over in endocrinology to help with some of these processes. And then the other one is the vascular considerations, peripheral vascular disease. Getting a sense up front, are we going to have a problem from an inflow standpoint or a problem from a venous congestion standpoint afterward? For healing, probably at the bony level, the arterial inflow is probably the more important piece. So consulting vascular medicine, vascular surgery, understanding when we need to get non-invasive studies, and then refer to our colleagues in vascular surgery to help with that. And in terms of optimization, is there any form of intervention that needs to happen before we're taking on some of these high-risk cases? And so here's a case review of mine. It is a 45-year-old female. She did have diabetes, which was controlled. She had previously had a retrograde drilling performed of her, I think it's on the next slide here, had a retrograde drilling performed of an osteochondral defect that resulted essentially in a cavitary defect of the talus that was quite large, where the talar dome collapsed down into the residual defect, and the retrograde drilling obviously was not successful. So we had critical bone defect uncontained at the talus in a patient with controlled diabetes. She's a 45-year-old female. The interesting thing about this case is, other than her diabetes, which is controlled, she's reasonably healthy. So from a metabolic standpoint, there wasn't a lot else that I was concerned about. And then when we look at the geographic nature of the defect that she has, the medial aspect of the talus, she has this large void, but the bone is largely healthy on the lateral extent. And so we'll talk about what we did here in a second, but I thought this was a really interesting test case for a product like Magnetos to see how it performs, one, over time, and two, over separate environments in the same patient within the same ankle. And so what we ended up doing was an ankle arthrodesis, and this is the CT scan 4 months after. I did cross screws with an anterior plate, and then used the Magnetos putty, as well as autograft from my patient with controlled diabetes. And in the medial aspect of the joint, the Magnetos is truly acting as a void filler. It's going to take some time to reincorporate through that entire defect that's there. Whereas to the more lateral and central aspects of the joint, where we had healthy bone-to-bone contact, we really had a primary arthrodesis. There was a thin spackling of the material that was placed, obviously throughout the entire fusion, but watching how that bone is going to behave and how the magnetos is going to interface with that over time on the medial aspect is going to be very interesting as well. And so this CT scan at 4 months. The image on the left is a coronal image, and you can see the difference between the lateral aspect of the fusion with primary bone-to-bone arthrodesis, and then to the medial aspect, you can see the residual magnetos and how it's behaving 4 months after. And I don't have all the answers to what that looks like. This is one that I hope to be able to continue to watch over time to see how that remodels in months and years to come. The central image there is a sagittal view looking at the magnetos more so in filling that cavitary defect, which is present within the talus, rather than looking at the primary arthrodesis. If you look closely, the other thing that's interesting here is this type of material. A lot of times in ankle arthrodesis, you'll have a little bit of a residual space in the posterior aspect of the joint once you get this appropriately reduced. And the magnetos, you can kind of see that white spackling along the far posterior aspect that filled in nicely there as well. And then the image all the way on the right, that's showing more the lateral aspect of the joint where you have primary arthrodesis. And again, you can see a few of the particulates associated with magnetos present, but largely primary arthrodesis with combination of the autograft as well as the magnetos, which was present. And as a final, here are some images. These are earlier images of x-rays. The CT confirmed arthrodesis at 4 months, but again, this is one that we will continue to follow.
That's amazing. I'm love seeing that part that integrated with that huge defect. All righty. So we are going to go with Alan, Dr. Ng, big experience out in Denver. Walk us through where the osteobiologics fit into this.
So I'll go in. Thanks for having me. Appreciate it. This is a great forum and great faculty we're talking about here tonight. And all due respect to Mark and Tom, I think the first few topics are essentially a given. I'm the elder statesman of the three of us, and back in the days when I was training, we knew that hardware was important. We knew that biology of a patient, diabetic control, and all those things were very important, and those should be done as a given or as a standard. So what's changed over the last 23 to 25 years that we're doing now to get better patient outcomes, right? So that's the whole goal of this, is that orthobiologic, osteobiologics, whatever you want to call it, allows us to have more predictable outcomes and better success for our patients for fusions. Back in the day when I started out, we had BBM, and that was like the miracle bone graft back in the day. I mean, comparative to what we had in the past to now is unbelievable. We have so many more options to enhance patient outcomes, and magnetos is one of the ones that I tend to lean towards because of its availability and its ability to help me use these tough cases. And you look at the history of orthobiologics or osteobiologics in our profession, most of it comes from spine, and that's where this started out, and it all trickles downhill, right? It always ends up in the foot. We look at old products like Infuse that started in spine, and now magnetos, which was initially a spine product and was utilized for interbody fusions with cervical cages to allow us to increase the ability to get bone to grow to metal to bone. So that's kind of the case I'm going to present. And all due respect to Mark and Tom, the stuff they talked about, in my opinion, is a given. So right, you need to have good hardware. You need to understand the biology, get these patients tuned up, get them healthy. But what the biggest variable that we can control now is what are we using in these fusions to make these things fuse faster? What are they using to help get better patient outcomes, get them back on their feet again with solid osseous fusion? And I think, ever since I've been doing fusions back 20-something years, I've always used some sort of biologic or orthobiologic to help increase the odds in my favor. And now that I think we have better technology, these odds are getting better and better. And in a product like magnetos, when we use this for a fusion, I feel more comfortable with the progression of fusion to get them healed within a faster period of time. Greg did a great presentation on when is it clinically fused. When do we know these patients don't hurt anymore? And in my experience, it's usually about 50% of the joint to be fused in order for them to really, truly not be in discomfort. 25% they called it essentially you're going to fuse, but 25% isn't enough in my opinion. These patients still hurt with that much fusion. So we need to do everything we can to push the odds in our favor to increase the ability for these joints to fuse. So I'm going to present a case here. This is a tough case that was referred to me from one of my partners. This is a 64 year old female, had a history of attempted subtalar joint fusion. And unfortunately, she ended up with a subcondyle collapse and talar AVN secondary to the attempted fusion procedure, with obviously you see here screws violating the ankle joint. Started having a lot of discomfort and showed the collapse and failure of the fusion and also the AVN. So this is difficult. So sent to one of my partners, ended up taking care of this patient, ended up going in and revising this to a what we call a Death Star cage fusion with a TTC nail. Obviously, when we talk about biology, this patient's a type 2 diabetics, neuropathic, hypertensive coronary artery disease, lots of a lot of things that, you know, obviously we know biology is going to be a problem. We have to optimize our A1C and make sure everything, as well as vitamin D and all those things we normally would do in a typical patient workup. Then we talk about fixation. Obviously, we want to put something stable in there. We want to bridge the deficit due to the volume lost from the AVN. So now we're talking about using technology that we didn't have back in the old days, and now we're printing essentially a talus that we call a Death Star. That's a trabeculated metal that allows us to on-grow bone to the interface between the tibia and the calcaneus. So what happened in this case here is this patient presented and started ambulating on this extremity and then resulted in essentially a failure. So preoperative x-rays, you can see here on the left, showing that the nail's in place, the Death Star or cage is in place, and then all of a sudden you get a CT scan, the patient comes in with a lot of pain, and you see the nail has broken in the cage itself. So the question is, why did this happen? You know, and the main reason this happened is because we didn't get incorporation or on growth from the cage to bone interface. And you can see on that bottom right axial cut of that CT scan, there's a nice black halo around the cage. So it did not incorporate. And when you start looking at this, you figure out, you're looking at biology, you're looking at your hardware. I don't think there's anything wrong with the hardware. Biology wise, yeah, probably not your best, you know, host for fusion being diabetic. But in this case here, we've gotten diabetics to fuse before, all of us have. And now we got to figure out how to get this one healed. So looking at this, it's complicated because now you have a failed cage with a failed nail. And now you got to figure out how to get this patient to salvage their limb. So in this case here, my operative plan was to explant. I did do a cement spacer prior to the definitive revision. So we explanted the previous cage and the previous nail, which is always a fun thing to do. Luckily, we were able to extract it pretty easily. We put a cement spacer in for about 6 to 8 weeks, put on an antibiotic holiday just to make sure there's no signs of infection, and then went ahead and planned the revision. Obviously, a 3D printed plan with maybe better hardware as regarding to the first, with Tom's talk about making sure your hardware is solid. In this case here, we built out the cage to ensure we had cortical coverage, medial, lateral, anterior, and posterior to give more of a stable base for the implant so it didn't subside or sink. We also nailed it again with a little longer nail and planned for incorporation utilizing our orthobiologics. In this case here, we know that MagnetOs has a great track record in the spine. Obviously in spine, there's a lot of interbody fusions with cages. And that's when I first started learning about MagnetOs. And in this case here, why not in the foot and ankle, right? We're using 3D printed cages, we're using metal. We need metal to grow into bone to grow into metal, right? So how can I enhance the ability for my patient to on-grow from their tibia, from their calcaneus into my cage? It made total sense with the needle technology, the ability for the MagnetOs to stick to my cage. I can mold it in on the cage and interface that into that area to enhance my ability to heal on a patient that already failed the same type of surgery in the past. So obviously we went in there and we re-prepped the bone, we re-reamed the area and placed our cage, but this time our cage is enhanced with the orthobiologic. And that's a variable we have now that we didn't really truly have 20 plus years ago, even 10, 15 years ago. The technology and the science behind using these orthobiologics has, in my opinion, the game changer on these big limb salvage or even in your primary fusions. There's not a fusion in the foot except for a hammer toe that I won't use something to enhance the ability for my joints to fuse. So we want to push all the odds in our favor. So we want to look and see how this goes. This patient gets the cage revision. The cage is coated. I don't coat inside of the cage or put anything in the cage. I think it's a nidus for infection. I only coat the outer surface that interfaces with the bone. So as we progress 5 months post-op, we start seeing this patient. It's looking pretty good. You know, looking at those radiographs, it looks pretty solid. I think we got bone onlay and on growth in the area, but the key is the CT scan. Look at the difference between this CT scan and the previous CT scan. There's not that dark halo. It's showing inner on growth onto the cage. You can see those areas fill in, and this is essentially now a stable construct or a TTC fusion on a patient that had failed before. And the question is, why success now versus failure before? Is it the orthobiologics? Is it surgeon? Hard to say. I would lean more towards the orthobiologics in this case because they did the exact same procedure that my partner did. My partner's a very good surgeon, but just didn't fuse. Only difference between the two surgeries that we did essentially is that I coated this cage with orthobiologic, was magnetos, which enhanced the ability for that host to grow bone onto my cage and to stabilize the area. So I think you look at these the two cases, this case I just presented, there's a difference between index procedure with no enhancement of the fusion to the revision procedure with enhancement, and it worked. Is there some concept of the hardware? Yeah, I probably made a better cage. I made sure there was coverage, cortical coverage, just like in a total ankle. We want to make sure that the vortex is on the metal, so it's not going to chances to subside or move. And obviously the failure was due to motion, and the previous nail fractured in the cage. So in this case here, we were able to salvage this extremity, and by using the orthobiologics to enhance our chances of fusion. All right.
All right. That's amazing. Thanks, guys. Really solid points of view. And I'm not going to pitch you against each other, but I am going to dig in a little bit on some of the points. So the first is, let's go back to the previous slide, please, Scott. So the first one is, what are we talking about? And magnetos, that's how we pronounce it, is a third generation synthetic calcium phosphate. Its secret is its architecture. This microarchitecture is where the word needle came from. And it's got a very solid scientific basis. Kuros is a science company. They lead with science. It's in the DNA of them. And they have a very large experience in spine. The experience in foot and ankle is a bit younger, less than 5 years. But this is a story that I won't take you through, but it's a 20, 30-year story about how we are here today. And I will show you a little bit more of that science later. Product formulations. Easy Pack is the most malleable that is available. Putty is also moldable, but a little more firmer. So with that, let me go and kind of work our way through what we just heard. So Tom, hardware is king. You're a sexy guy on TikTok. Do you dance on TikTok, or do you just like present your cases?
I mean, you have to dance, right?
Okay, good. All right. So Tom, the dancing guy on TikTok. All right. You showed a nail. Was that a dynamic nail, nitinol nail, static nail? Let's talk to me about nail technology in 2025.
Yeah, so especially in that instance, my general rule of thumb is I love dynamic fixation, but I don't combine dynamic and static fixation at the same time, because then I've kind of defeated the purpose of the dynamic fixation other than adding expense. So knowing that I was putting a TTC plate over that nail, that would have negated any dynamic effect there. So static nail, static plate, static everything over the top there. I will frequently use, in different instances, I'll use dynamic staples. And then I'll use partially threaded headed screws to allow that fusion site to compress a little bit down those, depending on the fusion site, though.
Okay. So order of operation, nail goes in, and then you fire the screws around the nail?
Correct. Yeah. Nail goes in. Nail is my primary fixation there because it's intermedullary. It's better load sharing for that patient that I know is going to be weight bearing. And then plate goes over top of the fibula, and then do my best to miss the nail with all those screws. And especially on that one, got lucky and missed on almost all of them. Had to abort 1 or 2 screws, I think, but the rest of them we were able to miss.
Okay. I will accept that you got rigid fixation with a non-dynamic nail because you put the plate there. if you just use the nail alone, non-dynamic, do you think you get primary bone healing, or are you going more for creeping substitution, slow secondary bone healing?
If I just use a static nail, or if I just use a dynamic nail?
Static nail.
If I use a static nail, I think you're getting probably a little bit more bony callus formation there.
Okay.
Yeah,
I
because I think
agree
especially
with you.
with that graft, I think you're going to get some resorption.
Alan, you pipe in on this one too. Do you think, so just to state the obvious, dynamic nails have really taken the market in a
Yep.
large measure. Do you think that the dynamic nails are getting primary or secondary bone healing?
So in theory, the nitinol or compressive nails should get primary bone healing. They should, but these, to go towards what we're talking about biology wise, these hosts are awful. So some of these dynamic nails are too powerful or too strong. You're going to end up causing subsidence, and you're compressing that area. You may lose some volume if it's too compressive. So you have to be very careful about that. But in theory, if they're giving an adequate compression in the bone on bone apposition and there's not motion, then if you've locked it in place, it's not rotating, in theory, it should be primary bone healing. It should be based on principle. But are we getting that? Probably. Obviously, we all seen these nails fail. We've all seen these bones sink. So, a lot of times I don't think we're getting that. We're just happy to get fusion. If we get a big bone callus on the area, it's not necessarily a bad thing, and it may be secondary. But the ones we're using, these dynamic nails or even static nails, are bad hosts. These are tough fusions.
Alan, you're such a smart guy. I agree with you all the way. Is that I think our dynamic nails are getting enough compression, and you get the friction fit because of the compression, that you are getting very much primary stability. You can get primary bone healing. But the unanswered question as of now is, how hard can you pull? It's not a limit of the hardware. So Tom, hardware is king. I'll reassure you both that we can pull harder than we currently are. The big limitation is, should we? And how do we figure out which patients to pull hard on and which ones that you have to just back off a little bit? So, Mark, I like your patient biology perspective. Do you think patients are open to recognizing themselves as poor hosts? How do you tiptoe through that without saying that you're fat and unhealthy?
I think that you have to dance delicately and kind of read the room. Some probably are, and some are not. The ones that probably are interested in it are less likely to be the hosts that you're really concerned about. And so I think that's part of the challenge, and I think that's part of the art to medicine, more so than the glorified carpentry that we do. Is the time spent in the clinic really helps us determine, not only we have to pick off and use our doctor brains to figure out where the biologic challenges or the physiologic challenges in these patients are before we put our carpenter hat on and go to the operating room. And so I think that's where we make decisions, typically sometimes only in a few minutes in the clinic, deciding what hardware we're going to use, deciding what biologics we're going to introduce, and then match that to the patient and the patient biology to put it all together. And so really, I don't think it's any one of these things individually that solves the entire problem. I think it's a combination of us as the surgeon piecing the whole story together and trying to do that with something that's backed by some science, partnering with like-minded, whatever that means for you, like-minded, whether it's the hardware company or the biologic company or whatever it is, to figure out what story makes the most sense to you, that has the most data behind it, to try to get the most effective result for your patient, and then to be really transparent with your patient through the process, so they understand what some of their risks are, and you can help them understand the ways that you're going to try to mitigate those risks. But ultimately, there's still risk to all of these situations.
Yeah, I like the way you say that. There was an era in my career where I used a lot of bone growth stimulators, and the research was kind of but what I liked is it involved the patient in their own care. So I could tell if they were using it or not, and it just was a way for me to force them to participate. The insurance companies took care of that issue. Do you have one number that patients seem to resonate with, like vitamin D, or is there something that they nod their head when you say, yeah, you know what, we got a bit of an issue, we need to work on it together?
Yeah, I mean, I think in diabetes, there's pretty good data that supports A1Cs over 7.5 are associated with increased risk. So that's pretty easy to jump to. The vitamin D one is a little bit confusing because I personally feel that the normal level of 30 may be fine if you don't have a bone to heal, just to carry on with your daily life. But if you have to be metabolically active, I think that's probably still insufficient. And so I like to see them higher. And so there's some room for optimization on some of that. And for some people, you can get buy-in on that. It's interesting because some, they may be seeing their primary doctor and their primary doctor may be fully comfortable with them if 31 is a normal lab in the vitamin D range for them carrying on their daily life. But for us to need to get in a challenged host, a fusion, we may want to see something that's better than that. So I think it really depends on, what metabolic marker we're looking at and whether we have a good target to chase or not. Some of them we do, some of them we don't. And I don't know that part of it's, because we're, like Al said, we're never really going to, in a lot of these challenging cases, we're never really going to get a truly optimized host. It's unusual that we kind of have the perfect patient to do these challenging surgeries on. And so I think we work to try to optimize what we can and work with the medical team around that patient to try to give us the best opportunity, but we're never going to get the perfect patient.
Well said. So Al, how do you talk to your patients about the biologic augmentation that you're going to use? Very pointed questions. Do you put it on your consent? Do you tell them, hey, you're a compromised host, using nicer words than that, but I'm going to use things to help you heal? How do you get them excited that you're going to use what we consider very exciting technology?
I tell them I'm throwing the kitchen sink at them. Pure and simple. I'm going to use whatever I can use to get you to fuse. And I look at your body habitus, your nutritional status, your metabolic ability to heal. And then I need to work around that to make sure I can optimize all those factors and then optimize your surgery interoperatively. So I tell them that, you know what? You're not the best host. You need to do your best job to, one, lose weight, get your diabetes under control, get your vitamin D optimized. And my magic number is 55 plus is my vitamin D number I want. And if they have a history of osteoporosis or history of fragility fractures, I'll send them to the bone clinic and put on anabolics, put them on Timlos or Forteo to really enhance their ability to heal. So I have that discussion with them saying that, I'm going to use the best thing I can possibly use to get your bone to heal. And then in my hands right now, it's Magnetos is easily available. It's available whenever I need it. The problem with some of the other materials is not.
I'm a script guy, and what I heard you say is I'm going to use whatever it takes to make you fuse. So
right.
That's your quotation. You're going to hear that one come back.
100%.
Mark, do you have a script that you use with them?
The words that seem to gravitate are optimize and stimulate. And, you really kind of tell the story by basically sharing with the patient, hey, you're doing everything you can. And so you can optimize fixation, you can optimize osteobiologics, you can optimize the patient, you can optimize all these things. As the surgeon, we can only meet the patient halfway. And to get buy-in from them in terms of their biology, that's where you can lean on them a little bit and say, hey, here are these things that I'm doing for you. This is where I need a little help. This isn't urgent. We can do this 3 months from now. Can you get that A1C down a full point or 2 points? Can you lose 20 pounds? Can you go see a nutritionist and make sure that you're getting a high protein diet? All of those things to help try to provide the host to give the best opportunity for everybody to have a successful outcome.
Good. Hey, Tom, how do you describe Magnetos to your patients?
I tell them that I'm going to give them the best graft that I can give them, that I can pull off the shelf, that is going to be the best opportunity for them to grow bone wherever I need that bone to grow.
Okay.
I keep it simple.
No, I like it. I think that's great. All right. We did really, really well there on working through that. I had put out a couple questions, which I think we've pretty more or less covered. And but the second one is kind of an interesting one. I'd love to hear you guys chime in on this. We've all agreed that patients are different and with different levels of health. Do you think there's patients that their autogenous bone is kind of not doing a whole heck of a lot because they're simply not healthy enough to support a healthy bone stock? What do you think of that one, Tom?
I mean, I would 100% agree. I mean, I look at, my go-to spots have always been either the calc or the tibial tubercle to harvest bone graft. And I've always been a relatively cheap guy, so I literally just use a curette and I go in there with a big old curette and scoop out Cancell's bone and put it in there. How many times do we go in there and you scoop out medullary bone and there's nothing there?
Fat.
It's just hollow,
Yeah.
So that's why I sit there and go, if you don't have any medullary bone, what are you growing? What is your bone doing? Your bone is biologically inert. It's just sitting there. It's not actually growing.
All right. I'm going to run this third question with all of you, and I'll start with Mark on the top. When using augments, how do you decide between proteins, which I defined as BMP and PDGF, and third gen synthetics, which is Magnetos?
Yeah, I mean, I think that some of it is where you need a void or where you have a void, something like the third generation synthetic. Magnetos has worked well in my practice for that, where I need to have a little bit more contouring or in that patient. And that's the nice thing about it being on the shelf is it's always available. Is that if you need something to add, you usually can pull it off the shelf and have it within a minute or two. You're not running to the freezer. There's not a thaw time. You're not really worried about that. So that's always kind of in my back pocket. On my fusions, that's typically going to be requested, kind of no matter what. The forefoot's a little bit different for me. I like lower profile stuff, like around the first MTP. If I'm really concerned about soft tissue, I'd want something that really contours super tightly to the joint, or just in general be careful about overuse of any product that you're using. We want adequate fill, not necessarily overfill. In my experience with a variety of different products, I've seen some challenges there. So just kind of cautionary tale to the audience in that regard. Adequate doesn't necessarily mean as much as you can possibly get in there. Adequate
just because it's in the pack doesn't mean you got to use it.
Yeah, so just be judicious and smart with that. In certain instances, revisions, that's where I'll jump to some of the protein products as well, and there may be opportunities to use those with autograft or use those with other carriers as well in certain circumstances where that makes sense. That's more the kitchen sink approach. That's usually where I'm going more to the protein products.
Okay, Alan, same question.
So yeah, I mean, the reality of what we're practicing now is cost, right? Cost and availability. A lot of these other proteins are expensive, but they do work. And availability isn't always the greatest. Your ASC is not going to want to bring in a $3,000-$4,000 protein in and say, why are you doing this? So how do I decide? It's availability and it's outcomes in my hands. So I know it works. I have it in all my facilities on the shelf. When I have a really bad case and where I need a last-ditch effort, I'll incorporate some of these proteins. But if I really want to really maximize my odds, I'll do that at times. But my majority of my fusions will get Magnetos as a primary, and if it's really a high risk or a really bad reconstruction, I'll add some proteins to it.
Good. All right, Tom, you get to close it.
Thanks, Alan, for stealing that one for me. My answer is pretty much identical to him.
Okay.
I mean, Magnetos has almost completely replaced proteins in my practice. The only time I will use them is if I do have a non-union. I will use some of the proteins every now and then if I've got something where I'm just drilling a little defect or I'm drilling a little non-union spot or something like that and just inject it in there. But cost has driven me, down this path, and then the results have kind of proven that, why am I going down the expensive path when I'm getting great results with the less expensive?
That's great. So good. All right, I am going to land the plane and just summarize what we've been talking about. First, an obvious statement: healing bone is hard work, and the expectations on all of us have never been higher. Medical care is super expensive. Failures to heal are even more expensive. And patients need to be able to trust us. Trust that we're doing everything that we can to do it once, do it really well, and let them get on with their life. And trust is earned. I think we'll all take the same pledge that we'll help our patients by committing and investing in knowledge. And if we're doing that, we understand bone healing, we understand what we can do to help them to heal, and we try and work on these scripts to communicate this complex ideas to them. The research is super clear. I biologically stimulate all my fusions. That's all primaries, all revisions. I routinely scan my patients at 12 weeks when I'm doing fusion, and that guides my post-op care. And the more I do this, the more humble I become as a surgeon. Our biologic choices are broad. Autograft or allograft, I use very little allograft. I will use autograft. If I'm using a protein, I tend to use PDGF because BMPs are off-label. And in synthetics, third generation is where we are at. I do not or accept the risks of cell-based allografts. I will argue against that to my last breath. They are dangerous. When we have a problem, we identify a need. So we need an alternative to autograft. As we said, our patients aren't all healthy and their graft is not necessarily useful to use. We have to be sensitive to health economics. We need to be able to use regularly, easily available, cost effective. Magnetos satisfies that. We want to be on label for foot and ankle use. And if we're going to do that, Magnetos is our new standard. It is an advanced biomaterial. It works by modulating the immune cell response. That's a new mechanism of action that nobody else can claim. And that's why this material works so well. It's all about the surface shape. The surface shape can influence cell behavior in newborn formation. It creates signaling pathways in osteogenic differentiation, and it's the immune response in the osteogenic differentiation of the cells that's new, that's different, and that is the secret sauce of Magnetos. Calcium phosphate alone is not inductive. So although this is a familiar compound, it's the way that Kuros treats calcium phosphate that creates this needle architecture. That's what makes it work. That's why it makes bone reliably. And that's why you can get some pretty interesting things. I'm not going to get way deep in the weeds, but it's really interesting to think that this immune system that we've always thought about as being for infection fighting is actually really, really helpful in growing bone. And that immune system is being turned on by this needle structure, which you're seeing on electron microscopy on your left side. How much data we have support this? A lot. Level 1 study. This is a level 1 study published in Spine. And this is a study comparing side to side in the same patients. And what they found was on the autograft side of this, remember, same patient, and this is just matched, 47% fusion on the autograft side, 79% on the Magnetos side, and the surgeons were not biased as they did this. Fine cut CTs, 1-year follow-up, level 1 data. Where does this fit for us in foot and ankle? Well, this is it, right? When you're in trouble, you want to bring the big hammer. So this is my case, 52-year-old female. She had a non-union subtalar arthrodesis and had successfully healed her midfoot. Why she healed her midfoot and not her hindfoot, I don't know. But what I know is she's not happy, and I'm now on operation 3. So we're going to swing, and we're going to swing hard. For me, that meant that I did the revision. I used Magnetos. I used the Easy Pack putty, and then I used a little bit upgraded hardware to satisfy Tom. What did we get there? I had fusion at 12 weeks, which is what we were trying to shoot for. Remember, I watched this out for a year as she suffered, and by 12 weeks, she's looking at me like, well, why didn't you do that the first time? So where are we with Magnetos? It's an advanced synthetic bone graft. Proven level 1 data. Level 1 data. You can go to your VAC with this all day, every day, and they'll just nod their head on the other side of the table. It's got predictable handling, and it's designed to stay put, so it's not going to flow away from your site. It's got a new mechanism of action that you've not heard about before. It's needle crypt, submicron surface technology that's turning on the immune system to help us heal. and it's cost effective. So VAC is over going there saying level 1, cost effective, put it on the shelf. This is interesting. This works. All right. So Scotty, I think you had some questions come in. Do you want to read those off quickly?
Yes, can you hear me?
Yep.
Great. Yeah, we'll go through these. Thank you all for the excellent conversations. Very, very interesting. Few questions. One came in. Which of the 3 variables that were debated do you feel is the most innovation upside over the next decade? For anyone?
Yeah, I don't know. That's what everybody was arguing, and I'm going to say that's a tie. I think Tom made a strong argument that metal has evolved and is continuing to evolve. I think Mark clearly pointed at the patient and said, we're not doing enough to really understand our patients. They aren't all the same. They're wildly different. And then Alan presented a case where Magnetos delivered something that the others couldn't. So I'm going to say they're all highly influential. And I think that's the challenge of our day is we can't be robots. We have to think in multiple things. And as Mark said, we've just got to be our best patient advocate and bring all to bear.
Great. A couple other questions that I thought were interesting. With an increase in use of weight-bearing CT, particularly at OFA, has this modality changed post-op protocols of your evaluation of a fusion? Any feelings of possible overestimation due a fusion with axial compression you get in a weight-bearing CT versus a non-weight-bearing?
All right, I'd love to know who asked that question. That is
Stephen
a really
Cooperman.
important and good question. We CT all of our fusions. My bias, and I've not been able to prove, is that there is a risk of overestimating fusion on weight-bearing CTs. We haven't actually taken that part on yet. We do have a large study going on in weight-bearing CTs with hindfoot nails, and it's a multi-center study that includes us and Duke and HSS is in, and maybe we'll answer that. But devil's in the details, and that's probably 4 or 5 years out.
And then last couple before we run out of time. It's an interesting one. Are you seeing any problems with or doing anything to optimize patients using GLP-1 medications?
Okay, that fits into Mark's.
Yeah, the biggest thing that we've seen there is time to surgery more so than anything else, making sure there's appropriate communication with the anesthesia side and the preoperative clearance team. At our centers, we've seen increases in times to be able to get these patients to ORs bump up to about 2 weeks. There's slower motility with regard to the gastric system and the GI system with those products. I'm not specifically familiar with the literature associated with absorption deficiencies associated with their utilization with GLP-1 utilization with regard to vitamin D or any protein products or anything like that. So I don't have that data off the top of my head. It certainly changed our time to surgery, just making sure that from aspiration risk that we're allowing enough time. But I'm not familiar if there's data out there to support whether or not we see some of the same malabsorption issues that we see in gastric bypass patients for those that are on GLP-1s.
Yeah.
I don't have that answer.
Just to chime in a little bit, is the GLPs are miracle drugs. Every time they get measured, somebody claims something else. It's not been looked at in a fusion model and where GLPs fit into that. Last question.
Does your osteobiologic preference change from hindfoot to midfoot to forefoot? Dr. Berlet, I'm sure I know you have an opinion on this, and Dr. Prissel, I believe you alluded to this as well.
Yeah, I'll let Mark answer that.
So for me, the one place I know Al said hammer toes don't get any sort of grafting necessarily. For MTP fusions, I think it's a space consideration, and I don't see those as much with critical defects that I have to worry about. I typically can get an appropriate supply of autograft from the calcaneus for those. As I start moving anywhere into the midfoot or the hindfoot, that's where I in my practice at this point am employing more utilization of the 3rd generation synthetic with Magnetos or alternate or other products depending on patient specific cases. But midfoot, hindfoot, ankle, absolutely 100% of the time. First MTP fusion if there's a bone defect. I think fill it, but otherwise for me, autograft has been sufficient in many of those cases. And again, I just caution for adequate fill and against overfill.
So I'm gonna counter you.
Run the list. So Al,
I'm gonna counter you, Mark. So I use this a ton of my first MBA fusions. The reason being, it allows me to contour that fusion. You can really compress the putty and get it to mold into that area of the fusion site, and you'll see that little rim of the magnetos in there afterwards. And then the speed to incorporation of that first MPJ fusion with this is one of the most impressive ones I've seen. And a lot of the cases I presented in the past were first MPJ fusions. I think the ability to contour and to fill that area, because you're drilling, you're fish scaling, you're prepping that surface. So the magnetos gets into those areas and allows it increase that stimulation of the growth of bone on those MPJ fusions. So I'll counter you on that one and say MPJ fusion is a great indication for this material.
all right, Tom, I'm going to let you have the last say on that one.
You really got to stop letting me go after Alan.
No, it's your opportunity.
This is my opportunity.
Hardware is king.
Hardware is king. Yeah, I mean, I can give you a lecture about hardware all day long. My graft of choice it has now for 5-6 years has been magnetos, and it's and again I'll agree with Mark. I don't graft my hammer toes, but virtually everything else is getting magnetos. I may supplement it here and there with a little bit of calc or tibia or something like that, just to make myself feel better every now and then. But it's first MPJ fusions, midfoot fusion, subtalar, ankle, you name it. I've even been using it in fractures and things like that. If I've got a big fracture gap, or if I've got fragments that got washed out from an open fracture or something like that, it's replaced just about everything. It's the one product that's living on the shelf for me. So
that's great. Well, guys, thank you. Thanks for sharing your wisdom, your experience, and your time with us tonight. I thought it was great, and I learned a lot from you.